Hello friends, I am Dr. Vijay Prakash and today I'll be talking to you about residual ridge resorption in an partially edentulous or completely edentulous patient. In a clinical practice, usually we find a patient coming to us who will be having one or two teeth, or maybe the entire jaw is edentulous, the completely edentulous patient, and he'll be complaining that my tissues are shrinking. And kindly tell me, doctor, how I can chew properly, because this prosthesis is not whatever he is wearing is not fitting well. Now, why that is because of? That is because of a process known as residual ridge resorption. Now, residual ridge resorption, or RRR, is by definition is a term used for diminishing quantity and quality of the residual ridge after the tooth are removed. And we can consider residual ridge resorption as a chronic, because it's over a long period of time that resorption occurs. Progressive, because at no period of time it is going to just stop and whatever bone has lost is lost. No, it is not going to happen. Over a period of time, some kind of resorption at varying rates will happen. Another thing, it is irreversible. Yes, it is irreversible. No matter what, the bone which is lost is not going to grow back, and it will never be the same as it was before. Another thing is also it is a cumulative oral disease. Now, what do you mean by cumulative? Because the annual loss of bone, they have a cumulative effect which leaves a reduced residual ridge over a period of time. This all happens once we remove the tooth. So once the patient, when we are removing the tooth, and then finally the empty sockets, the empty sockets are filled with blood to form blood clots, and during healing a new bone is laid down. Number of things happens here, and there is bone formation after some period of time, and the socket is covered by periosteum. And this residual ridge changes in shape and size at varying degrees in different individuals and in the same individual at different times. So it may happen that even in the same individual who is having different areas, like on the either side, you may find that there is more resorption on one side than the other side. That may all happen, and they may be at a varying rate. So rate of resorption can also vary. So rate of resorption actually occurs over a longer period of time, and it's a slow process. And as I told you before, that it is a cumulative process and a chronic process of a longer period of time, which may result in a reduced residual ridge. And that is where the maintenance phase is required. So it's not that you are making a complete denture for a edentulous patient and then you will not be seeing that patient. Now you have to recall that patient for a maintenance phase. There may be a need for relining or even rebasing of the processes. So how does it happen? The pathology of residual ridge resorption is that the ridge resorbs and reduces in size under the mucoperiosteum, and sometimes you may find there is, as I told you, there is a localized loss of bone, and this may also be accompanied by a loose tissue or a redundant tissue, a kind of a flabby tissue which is there over the ridge. So sometimes you may see a patient which is having a residual ridge, which is having in an edentulous patient, you may have a ridge, the tissues which you can feel and you can palpate, and you can see the entire say the anterior region is moving, because they are the redundant tissues or flabby tissues. So accordingly you have to plan for such cases. You may go for a pre-prosthetic surgery, or you may have to relieve that area when you are making impressions. So this is a pathologic process, and it is considered as an oral disease. And also you may consider that because it's a chronic and a progressive disease, you may also consider that it's a physiological change where the tissues shrink, the bone resorbs over a period of time, whether you are wearing dentures or you are not wearing dentures. whether you are undergoing a regular maintenance phase like for relining and rebasing, or you're not, the resorption may be slow. It is going to occur at different rates of that individual's lifetime. Now, these are 3D printed models of a patient who is completely edentulous. As you can see, this is the maxillary bone and this is the mandibular bone, which you can see. This is also a 3D printed model of a particular patient. Now, if you see the maxilla resorbs vertically and palatally. So what's going to happen is, over a period of time, this maxillary bone is going to go upwards and also towards the palate, and that's going to happen in the anterior region, and it is going to observe vertically and towards the medium, that is towards the midline, towards the center. It is going to occur in the posterior region. So in the center, it is going to go upwards and inwards, that is towards the center of the palate. That's the resorption pattern in the maxilla. That is centripetal type of resorption which is going to occur, which you are going to see, that is the resorption pattern in the maxilla. And similarly in the mandible, if we see the pattern of resorption here is in the anteriors, the resorption will occur vertically and lingually. So this bone is going to resorb lingually and vertically. Now this is a different patient than that patient which you see, because here if you see, the mandible bone is quite good in comparison with the maxillary bone, which is highly resorbed. Likewise in the posterior region, if we see, the mandible will resorb vertically and laterally, that is towards the outer region in the posterior region. So in the mandible, it is going to resorb outwards. So definitely in this you have a centrifugal type of bone resorption pattern in the mandible. So because of the progressive and cumulative bone resorption patterns of maxillary and mandibular ridges, you will find the maxilla becomes more narrower and the mandible becomes wider. So here if you see the mental foramen, it will be coming nearer to the crest of the ridge, and similarly if you see the incisal foramen, here it will be going closer to the crest of the alveolar ridge. Now at this stage, it is very important to understand what is the classification of these ridge resorption. There is one very important study which was done by Atwood in 1963, where they gave the classification in the form of order 1 to order 6. Now first order is pre-extraction. If you see, you have a good bone height, good bone width, and you have the tooth present. Now as soon as we do extraction, that is order 2, that is post extraction, once we remove, you can see the empty socket, but the ridge height and ridge width is almost similar to that of pre-extraction. Once resorption takes place, then you have the order 3, wherein you have a high well-rounded bone, that is order 3. You have a good bone, that is order 3. Order 4 is you have knife-edge ridge because of the resorption, residual resorption, and order 5 is low and well-rounded. You can see the height of the ridge is missing, only you have the width is getting wider, but at the same time you have very less bone. And order 6 is depressed type of ridge, which you can see. So Atwood classification basically help us in assessing the amount of bone, and accordingly we can take a decision what type of treatment would be best and ideal for that particular patient. Now just by seeing the patient, how will you know what would be the original height of the bone? Now the original height of the bone can be measured by a method suggested by Weichel and Scoop in 1974. According to them, you see the mental foramen, you can see that on the model, or you can see that on the X-ray. There you measure the distance between the lower border of the mandible and the lower border of the mental foramen. Suppose this distance is A. So the original height of the alveolar ridge of that mandible of that particular patient would be 3 times of this distance. That means it will be 3a. So this distance from the upper border of the mandible foramen to the original height, it would be 3 times. So that is how you can measure the original residual ridge height of that particular patient. So what are the causes of this residual ridge resorption? Actually, RRR is a multifactorial biomechanical disease which is because of multifactorial, as I just told you, multifactorial factors. Now, what are those factors? Let us see each one of them. One is anatomic factors. Residual ridge resorption will vary with the quantity and quality of the bone of the residual ridge because RRR is directly proportional to the anatomic factors. More the bone, there are more chances for resorption, but the rate at which it is going to resorb may vary from individual to individual and in the same individual from one location to another, and also at different stages of their lifetime. It can vary because there are other factors which is going to influence the rate of residual ridge resorption. Next, another important factor is metabolic factors. Now, residual ridge resorption is directly proportional to the bone resorption factors, but inversely proportional to the bone formation factors. So, as we know that residual ridge resorption is a localized loss of bone on the crest of residual ridge, and there are a number of local and systemic factors which may influence the rate at which resorption takes place. Now, what are these local factors? These local factors can be endotoxin, osteoclast activating factor, prostaglandins, heparin. It could be because of trauma. So all these are different local factors which can influence the rate of resorption. And systemic factors that can influence are those factors which can influence the balance between the bone formation and bone resorption. Usually what happens is the body tries to create equilibrium between the bone resorption and bone formation. So it tries to make the balance between the two. But because of some systemic factors, if this balance breaks, then there will be one or the other factor which will be more powerful. Also, if we see that these bone resorption factors or bone formation factors, the bone cells are influencing basically the rate of resorption. So the local factors or systemic factors can definitely play a big role in the rate of resorption. Next factor is the mechanical factors. Now, as we know, the remodeling of the bone is influenced by the force factor. So the amount of force which is directly there on the ridge will influence the rate of resorption. Like, for example, the amount of force, the frequency of force, the duration, how long that force is there, the direction of the force, whether the force is along the long axis or it is a lateral kind of a force, and also the area, how much area is covered by that force, and also the damping effect of the underlying tissues. All these are going to influence the rate of ridge resorption. Now, before going further, we need to understand the Wolff's law. What is the Wolff's law? So, according to the Wolff's law, the bone adapt according to the demand placed on them. Like, for example, if there is a high amount of stress, then the trabecular pattern will be such that they are going to form bone there so that they can bear that amount of force. For example, when you work your muscles, like if you exercise daily, then you put stress on your bones, and in response, your bone tissue is going to remodel and become stronger. And that is because of the Wolff's law, because the trabecular pattern will be in such a way that they can bear that force easily. Also, a very important study by Frost in 1973, where he observed that the trabeculae in these bones are oriented parallel to the direction of the compression deformation, allowing for the maximum resistance to deformation. So, the stronger these trabeculae are, the stronger the resistance to the functional forces. So if we see that residual resorption is directly proportional to the force, and it may increase in a patient with parafunctional habits such as clenching and night grinding of the teeth. So all these can influence the rate of resorption. The amount of force which is applied may be affected inversely by the damping effect or energy resorption. Now let us see what is damping effect. Now, as we know that the residual ridge is covered by periosteum, the mucoperiosteum, and damping effect takes place in the mucoperiosteum, which is viscoelastic in nature. So you have a greater energy absorbing quality, say where you are having a cancellous bone. So therefore, if we see the maxillary residual ridge is more broader, flatter, and have an increased cancellous bone than the mandible. So if we see this particular patient where you have the 3D printed model in front of you, if we see the maxilla, if you would have seen the mandible of this particular patient, it would have been even more resorbed, because in comparison to the maxilla, the mandible resorbs faster because of this particular reason, because in a maxillary bone you have more cancellous bone, more viscoelastic nature of the mucoperiosteum, greater energy resorption, and therefore if we see that you have a greater damping effect. So maxilla will be having a greater damping effect than the mandible, and therefore the rate of resorption of maxilla will be less in comparison to the mandible. So in short, if we see that the residual resorption will be inversely proportional to the damping effect. Now if we put all these factors together, we can make a formula, and we can say that the residual resorption is directly proportional to the anatomic factors. They are directly proportional to the bone resorption factors, but inversely proportional to bone formation factors. They are directly proportional to the force factor because of the particular reasons I gave you just now, and they are inversely proportional to the damping effect. Also, with time, RRR is also inversely proportional to time, because because of the cumulative effect of the residual resorption over a period of time. Residual resorption is going to take place because it is also a chronic and a progressive oral disease. So what is the treatment and prevention of residual resorption? Now the best way to prevent residual resorption is to avoid extraction of the tooth. So whenever possible, you should make sure that you don't extract the tooth. You should save that particular tooth as much as possible. That is the best way to reduce the amount of residual resorption. The treatment can be, you should go for a broad area coverage. So whenever you are fabricating a denture, make sure the impression which you are taking is covering the entire denture bearing area, and you have a good coverage with the help of denture. You are covering the entire denture bearing tissues so that the force is reduced per unit area on that particular area. So that is going to reduce the amount of resorption. Secondly, you should reduce the number of teeth which you are replacing in a denture. And third, you should reduce the buccolingual width of the teeth. So you should make a smaller teeth in comparison to the natural teeth where you have a broader buccolingual width of the teeth. You should use an anatomic teeth, because anatomic teeth provide a good sleeve space wherein the patient will not be applying too much of force in chewing. So if the patient is having anatomic teeth, he'll be able to chew better, and the amount of force which will be transmitted onto the residual ridge will be less, and this will result in less resorption. Next is centralization of occlusal contact, because centralization of occlusal contact will increase stability of the denture, and again it is going to reduce the amount of force on the residual ridge. Next way in which we can prevent or reduce the amount of resorption is by avoiding inclined planes. Another important factor, wherein whenever you are doing teeth arrangement, you should make sure that there is no inclined effect. Another thing is you should have adequate provision for the tongue space. You should have your denture should have adequate provision for that, because if you encroach in the tongue space, the denture will be unstable. The patient will be biting often in order to make that denture stay in the mouth, and again there will be more force on the residual ridges. Another thing is you should have adequate amount of intraocclusal space, because reduced intraocclusal space, if you're not providing freeway space, if you are not providing adequate freeway space, then chances of there'll be increased vertical dimension. More increased vertical dimension means more amount of stress on the residual ridges and faster the resorption. So these are all the factors which will help in treating and preventing, rather I will say minimizing the the rate of residual resorption. So here we come to end of our presentation. Thank you for watching the video.